Good morning, friends. We are here again with a new episode of our monthly webinar series. Good morning, friends. The topic for today is Approach to Limping Gait. I am Dr. Anupam Agarwal. The topic for today is Approach to This educational initiative is brought to you by Clinics India, GP Clinics, and dockieslive.com. Educational initiative is brought to you by Clinics India. GP Clinics, as you know, is our flagship journal being published every month for last 15 years. I thank all our readers for giving an overwhelming response to GP Clinics all these years. Friends, the recordings of all the previous webinars are available on our website gpclinics.in and on our YouTube channel dockieslive.com. Also, the summary of each webinar is published in GP Clinics print edition every month with answers to all the questions which you ask here. Dr. Y.K. Amdekar, with 50 years of experience, is the speaker for today's session as usual. So, over to you, sir.
Thank you, Anupam, and good morning, friends. I think today's topic is on a limping gait. As I've been always talking about, we are in this series picking up something that is not very, very common, but still is seen often in practice by all of you. And one of such things is a gait, and at times the patient presents with a limp. And often it could be a problem really to correctly diagnose what the problem is. So let's get about with the first slide. First slide, please. So I think if you look at what the gait is really means, it's the way the person walks. And there are many things that can be observed during this kind of a gait. And I think what is important is this is one important part of the physical examination, especially if the patient comes walking, you start looking at him and you can make out many, many other things. You can make out when there is a limp, where is the site of problem, and also what it could be the way the person walks. You can also see how fit or energetic he is or how confident is he. I'm sure you have seen the military person walking with great confidence and fitness. And I think the way one walks can mean so much, but even in terms of disease, and when we see patients, a gait is an important thing to talk about. Now, normal gait consists of a series of rhythmical alternate movement. We move our body and lower limbs as well as the upper limbs in a very rhythmic fashion. And uh, this, while doing it, we maintain our center of gravity and we are very stable during all these things. Each of these points is very important when it comes to seeing a patient with a typical gait abnormality. And I think normally, if you see while walking, our heel touches the ground first and thereafter the toes. And I think the only exception is a child under 2, 3 years of age often learns to walk while walking on toes, but this often disappears over time. And therefore, if it is there in a 2-year-old child, one may just observe it. And as his walking improves, and if he matures, then possibly he will walk the way we walk, heel first and toes later. The next slide, please. Now, these are the different types of gait abnormalities. And I'm sure all of you must have seen these kinds of abnormalities somewhere or the other, sometime or another. Okay. And uh, the one first and the most common is an antalgic, which means it's a painful limb. Usually it is unilateral, and I think typically a patient with a limb uses a very minimal pressure on the affected side to avoid the discomfort. And therefore, when he walks, the affected limb takes a very small lift and a very small pressure to avoid the discomfort. And you can make out closely which part of the limb is affected by looking at it. This is one common reason for a limping gait, and it is due to pain. But there are many other types of neurological disorders which also cause us different types of gait abnormalities. And I think one common that you may have seen in old age and senior citizen is a propulsive or a shuffling gait of a typical Parkinsonism. He has a forward bending, a very rigid posture, and he takes a short steps. And you all are very familiar with a Parkinson's shuffling gait. Well, sometimes we see a seizuring gait, which is typically of a spastic cerebral palsy, when the legs keep on crossing with each other because of a severe spasticity. Of course, you all have seen a hemiplegic gait, where because of the hemiplegia, the person has to circumdect the affected side because he has to clear the ground. And because of the paralysis of one side, he almost lifts up his affected limb and cannot put it straight onto the ground, but has to circumduct to avoid clearing off the ground. And I'm sure all of us have seen this circumduction uh, while walking in a hemiplegic child. A person, normally we judge the height of a staircase, for example. And when you go up or down the staircase, you are able to judge with a normal sensory system the height of a stair. And therefore, you don't have a sudden stamping. But when there is a peripheral neuropathy, you get what is known as a stepping gait or a stamping gait, and the person cannot judge the height of a stair, and therefore that's typical of a peripheral neuropathy. At times you see a waddling gait, almost like a duck, and this waddling is due to a problem in the glutei muscles due to, say, a congenital dislocation of the hip. And this is also seen typically in uh, muscular dystrophies, Duchenne muscular dystrophy, where the glutea are mainly involved. And to keep up the balance and the gravity, a person waddles, that means moves like a duck. And it's called typically a waddling gait, and it's seen in hip problems. Well, we are all aware of an ataxic gait, like a drunken person's gait, and you see that in any kind of ataxia, often cerebellar, but sometimes even a posterior column ataxia. And lastly, the couching gait, where a person bends down his hips, knees, ankles, etc., to kind of uh, relieve some painful condition, typically an abdominal severe pain. The patient bends down and walks. And such kind of orthopedic and the neurological problems can be easily seen from a distance by the gait that one can seize. And I'm sure you must have seen all these types of gait abnormalities. But all these patients come to you and me only saying that there is a limp while walking. And we need to fish out what kind of abnormality you have. Having given this basic information, can I have the next slide, please? The next slide talks about a clinical approach to a patient who presents with a limp while walking. And the first step, of course, is to find out whether there is a painful abnormality in the gait or a painless. Friends, we all know that painful abnormality is almost always inflammatory disease, which could be either traumatic or maybe infective or even non-infective inflammation, like a collagen vascular disorders, etc. But occasionally, not commonly, the pain also could be neurogenic. So don't forget that not every painful limb is often inflammatory, but occasionally it could be also neurogenic. And keep that in mind. Of course, the most common cause is really an inflammation. But when you separate out the two, painful versus painless, then I think painless is almost always neurogenic, while the painful mostly is inflammatory, but occasionally neuro. And when painless gait is neurogenic, it could be out of any abnormality in the sensory system or a motor system. And motor system includes, of course, the power, the tone, in coordination, or abnormal movements. And I think make it a further attempt to find out in a painless gait abnormality, which part of the neurological system is involved? Is it a sensory system or a motor system? And we all know that sensory system usually comes with tingling, numbness, or sometimes even a little pain. But a motor system comes with commonly loss of power or sometimes only the loss of tone, but also in coordination, like ataxia in a cerebellar or a posterior columns disorders and abnormal movements like tremors or many others. And we did one session on abnormal movements. So once you decide clinically between painful and painless limb, we can go further and observe the patient uh, to see how exactly his posture is. First, check up when he's standing, okay, and then make him walk and see how his gait gives you an idea. And what do you look at the gait? You look at first the two important phases of our gait. One is a stance phase and another is a swing phase. What is a stance phase? When foot is on the ground, from the time that foot touches the ground till it leaves the ground, is called a stance phase. So when I touch my left foot on the ground until I leave it, that is my stance phase. And a swing phase is when the foot is off the ground, from the time the foot leaves the ground to the time that the foot is on the ground. So when the foot is on the ground, stand phase, and when is off the foot, we are putting the next foot on. It's a swing phase. Each phase is to be closely observed, and then beside that, you watch the stride. What is the stride? Now, really, the distance between the two steps. An average distance varies, say, between 12 and 18 inches, but we know that Parkinson's shuffling gait, the stride is extremely small, and he just puts up few inches of stride, and that's why we call it a shuffling. He shuffles, he does not put up the leg ahead about 12 inches or so, and that thing is called a stride. And besides looking at both the stance phase, swing phase, and also the stride, we also watch for the foot angle, which means that are the steps parallel in the line of progression, or are the steps going haywire and not in a straight line as one wants to progress in a particular direction. I think if you learn to look at gait with this view, that you want to look at pain or no pain, and then observe the gait very closely, you can almost make out the site of the affection that is causing the limb, and also possibly you have a probable cause also that can be derived. I think this is important, but the reason why I brought this topic is we often do not look at the gait at all with all these details. And just uh, out of a joke, I remember when three orthopedic surgeons, one each specializing in hip joint, knee joint, and ankle joint, were discussing when they saw a man limping. And each one boasted that it must be due to the hip. The knee expert said it was due to a knee problem, and the ankle specialist said, I'm sure it's an ankle joint problem. So it's not easy, friends, to make out all these details, but once we have this in mind and we start looking at it, I'm sure today, when you walk on the road, you might start looking at the way people are walking. Okay. And I think this kind of observation helps. So when these three gentlemen who were specializing in different joint areas saw this man limping, they called him and they said, can we examine you because you are limping? He said, no, there is nothing wrong with me. He said, no, no, but you are limping. He said, no, I have a new shoe and that is hurting me. That's why I'm limping. The point I'm making is it's not easy to make out, but once you get a hang of looking at it, and I'm sure you do, can make out something much more than what otherwise we could have easily missed. Having given all this idea, let's see, as usual, some cases and you vote for what you feel is one way or another. Let's have another case. Next slide, please. Now, this is your first case. This is a 4-year-old child who presented with a left knee dull pain and then he was limping. There was no history of trauma or fever. He, his gait is an antalgic gait, which means he is obviously having a pain on the left side, and the local examination of the knee as well as the detailed neurological examination was normal. Make a note. He has obviously an antalgic gait, suggesting he has a left lower limb painful lesion somewhere. He's complaining of a knee pain, but on examination, everything is normal. Your options are he may have had a ligamental injury. It could be an early sign of an arthritis coming up in the knee. It could be sciatica. It could be a neurological pain. Or it could be really something else, none of the above. Your time starts now. Well, it's fairly equally divided earlier, I thought, but majority of you felt it was a ligamental injury, and nobody feels it's sciatica. So that's a good thing. But that everybody thought it was an inflammatory swelling, inflammatory pain, and therefore neurological pain is ruled out. Sciatica pain typically would be a shooting all that. Now the point is, if it was a ligament injury in the knee or an early arthritis, you would have had some clinical signs of a local inflammation, restriction of movements, okay, some stiffness. There is nothing of that kind. So obviously the knee joint on examination is absolutely normal. And therefore, those who opted for none of the above, that's the right answer. But the question is, what is none of the above? I wanted to bring this case only to impress on you. And we have done this once when we discussed pain as a topic, that the pain is often inflammatory, but it could be neurogenic, vasogenic, psychogenic, or referred. And don't forget that a hip joint pain is often referred to knee. And when you see anybody with a knee pain, make an effort to also examine the hip joint on the same side, because the hip joint pathology may present with a referred pain to the knee, and you might examine the knee, you might ask for a CT scan, MRI, and everything will be normal. And therefore, keep a note that referred pain is often seen in clinical practice, and you all are very good at knowing a referred pain of a myocardial infarct, which could not only be at the precordium, but it could be at the left shoulder, or sometimes even the neck, or a throat, or even a left jaw. And I think you need to be very careful about such a problem. And this was just to show you that referred pain could really make us completely go amiss. Can I have the next slide, please? The next case is a 10-year-old child who presented with a limb and pain in the groin, aggravated by activity and relieved by rest. He's complaining about the groin pain, and on examination, there is a stiffness and restriction of left hip joint movements. So you have obviously a left joint pathology, hip joint pathology, and now it is a limb that is being produced in a 10-year-old. He has obviously no fever. So your options are, could it be rheumatoid arthritis? Could it be tuberculous arthritis? Could it be traumatic synovitis? Or could it be something totally else? Your time starts now. Well, majority of you have voted. Certainly, you have ruled out rheumatoid arthritis, but yes, there are few. But majority of you seem to be uh, favoring traumatic synovitis. Can I have the slide, please? Yes, you are right. But a 10-year-old will not miss the history of trauma. Had it been a 2-year-old child who had just started walking and he has injured subconsciously, you would easily miss traumatic synovitis in a year and a half or a 2-year-old child, because he cannot pinpoint easily. But he suddenly starts crying. But a 10-year-old who suddenly gets a kind of a trauma, maybe while playing football or maybe running or maybe jumping, he would remember the onset, that it suddenly started, and there was no such history on this child. You could have asked for this history, obviously. I did not want to give this history because then you would have jumped up to say traumatic synovitis. So you are reasonably right in considering traumatic synovitis, but a 10-year-old will obviously know the onset of trauma, that he suddenly got a catch, he was jumping, playing, etc. And he will not come only with a limb, but he would come and say that he suddenly developed something and it started paining even before a limb came. And the point that I'm making is, such small details and a good thought process would make you feel that while it looked very likely a traumatic synovitis, rheumatoid arthritis is out. It's a chronic problem and it presents slowly, often just morning stiffness and nothing else. After a long period of days or weeks, you start getting some more symptoms. And hip is not a common area of involvement of a typical rheumatoid arthritis. Knee is very often, or ankle. TB arthritis doesn't start with suddenly a pain as the main feature, and therefore there could be a limb, but again, a 10-year-old would also have an issue. Typically, a a tuberculous arthritis or any beginning of arthritis has a pain at night. He wakes up in the middle of the night with pain, but thereafter, once he starts moving, he's generally all right. As an early symptom of arthritis of a mild degree, like a tuberculous arthritis. Therefore, when you have nothing of this kind that is easily seen, you start wondering whether he has some disease localized to the hip, but it's not inflammatory, and therefore this pain is really a vasogenic pain. And this is known as a Perthes disease. It's not important to know what Perthes disease is really, but what happens in Perthes disease is a blood vessel supplying the head of the femur gets blocked, and gradually the head of the femur, devoid of blood supply, starts getting necrosis. And that largely starts causing pain, but on rest he is relieved because there is no movement of the head of the femur. But when he starts activity, he starts paining. That's very typical of a Perthes disease that is totally relieved by rest but aggravated by thing. Again, I'm sure you may not have seen Perthes disease at all, but I wanted to bring this again to show you that how small few points that you take a note of can make a lot of difference in our analysis. That this child has pain and is limping, but as soon as he takes rest, he is all right, he has no pain, and activity is worsening his pain. And therefore, also one factor that you ask for pain is what aggravates and what relieves it also. Can I have the next slide, please? The next slide, please. Now, the next slide is a young adult who presented with falling while walking off and on for no apparent reason for about 1 month. Imagine he's just falling down and he therefore comes to you with a problem of walking. Okay, he may get a mild injury while falling down, but all that he has therefore is when you see him walking, he has got a very wide base gait and he's very unstable, while sitting also. So he has a lot of instability. He's unstable, and that's why he's falling. And he has got a very wide base gait. His legs are wide apart when he's walking, which means that he has to keep his legs apart to keep his balance or a center of gravity. The way you walk on a ship which is moving, you keep your legs a little away from each other to keep your balance. And he's walking with that kind of wide base gait. And your options of this person's problem is one, whether there is purely he's inattentive and he's in a hurry, so he falls down, whether he has got any motor system disorder, whether he has any sensory system disorder, or whether he has a cerebellar disorder. Your time starts now. Excellent. Well, you are right. All of you are right. Why all of you are right? Because the motor system includes also incoordination. And the commonest cause of such incoordination in this person who is ataxic is a cerebellar disorder. I just wanted, can I have the slide back? I just wanted to bring this simple problem, okay, because at times the ataxia may not be cerebellar, but it could be a posterior column sensation abnormality. And I think don't miss it. Well, uh, even the vestibular ataxia is known, but generally it is not chronic. It comes as an acute episode, like a Meniere syndrome, and doesn't present with ataxia as a problem, but they present almost like They feel unstable while standing or walking, but it comes in an acute attack. Therefore, just to keep in mind that when you see ataxia or incoordination, you may also keep in mind a possible posterior column sensory defect, and you must test not only just the pain but the deep pressure pain or temperature, and therefore do look carefully for any sensory system involvement. Can I have the next slide, please? The next slide is again a young adult who presented with a limping gait for the last 1 month. He is gradually worsening. He is painful while walking. Okay, take a note of all this. He shows a mild weakness of the right foot and ankle jerk is absent. He is developing this over a month and he has an ankle jerk absent. Okay, and there is a mild weakness of the right foot. Now, your options are peripheral neuropathy, polio-like illness, a spinal tumor, or a transverse myelitis. Your time starts now. Well, I'm very glad. Can I have the slide back? That almost large number of you voted for a spinal tumor. And a few of you thought also whether it could be a transverse myelitis. In a transverse myelitis, when there is a total transverse lesion over the spinal cord, going across the spinal cord, you generally have an acute onset problem, not chronic. That is one. And second is, even both sides are involved, not one side. And you may also have a bladder and bowel involvement. In absence of this, of course, this is not a peripheral neuropathy. There is no tingling numbness. This is not a polio-like illness because in polio-like illness, it's motor system but not sensory system. Pain is very transient in polio-like illness, and mostly the polio-like illness, today we don't see polio, but any other viral infection like an enterovirus can cause polio-like illness. But then this anterior onset disorder is a purely motor disorder. The pain is not a feature, and also it is often patchy. It is not just localized to one area alone. Knowing that it has been going on over a month and gradually causing this kind of a problem, he has possibly a spinal tumor. And I again wanted to bring this because here is a pain and also weakness, and that tells you that this is a neurogenic pain because there is a weakness and going on over a long time. Whatever happens over a long time of few weeks is likely to be not an infection or an acute inflammation, but a space occupying lesion. And don't miss this. A clinical examination of the spine may not show any abnormality unless the problem is in the vertebrae itself, like a TB spine, for example. But the clinical finding, what is the importance? Every limb that the patient presents, you must have a thorough orthopedic and neurological examination. And I think this is important. Mere orthopedic examination alone may not suffice, and neurological problems also do exist. Can I have the next slide, please? Now, the next is again a small child who presented with a funny gait. He's rocking side to side with uh, shorter steps and could manage walking but with difficulty. And he showed a restricted abduction of the right hip. There was no pain. So he is having a waddling gait to keep up his center of gravity, and he has a restricted abduction of right hip. Right hip cannot be abducted, and this is painless. So your options are: he has got a synovitis of hip joint. You may have a Perthes disease that we talked of earlier. This could be a congenital dislocation of hip, or it could be chronic arthritis. Your time starts now. Perfect. What a score. Excellent. Okay. Can I have the slide back? The point I wanted to make here again is younger the child who comes with a limping, do not forget some congenital malformations like Perthes disease was in a small child, and this is a congenital dislocation of hip. This is one defect which is often missed till child starts walking, and even when child starts walking, he manages walking. He doesn't fall down. So people at the most feel that he would learn to walk more and more stable and more properly. And therefore, the diagnosis of a congenital dislocation of hip is today called as the dysplasia, is often delayed. And if it's delayed, then you need a lot of surgical intervention. Whereas if you pick up this in a small infant, this is one important part of a neonatal examination, that you should not miss a congenital dislocation of one hip. And this is done by simply trying to abduct both the hips. So you flex both the hip joints and try to abduct them. And you find that one side can be abducted very easily, whereas the other side cannot. There are two, three different procedures, maneuvers called Otto-Noli and Barlow's procedures. But what is important is flex both the knees and hips, and then try to abduct both the hips. And if you find a difference between one side not getting abducted easily, you know that is probably a dislocated hip. An important point to diagnose as early as possible, and you can diagnose it before the child even sits or stands or walks. And in that case, a mere uh, plaster or a hip spike can make the child completely all right without any surgical intervention. This is one area where an early diagnosis, you don't wait for the limp to occur, but yes, we do see such a child presented to us with a limping gait. And this was just to make you aware that some of these things can be diagnosed even before the gait starts limping. Can I have the next slide, please? The next case is another 2-year-old who presented with delayed onset of walking at 20 months of age. He uses short steps with rocking side to side and a toe walking. His maternal uncle had also similar problem, and he died at the age of 18 years. Make a note. He has a delayed onset of walking. He's walking in a funny way. He's almost waddling, rocking from side to side. And he also has a toe walking. He's walking on his toes. But the history of family, a maternal uncle dying at the age of 18 years for such a disease, and examination only showed that he has a lordosis. Okay, which is unusual at this age. At this age, generally, they have a kyphosis. Your options are He has a cerebral palsy. He has got a congenital dislocation of the hip. He has a degenerative brain disease or a degenerative muscle disease. Your time starts now. Excellent. Again, wonderful. Can I have the slide back? This case illustrates the need for asking for a family history. I'm sure as an undergraduate, we have heard a chief complaint, origin, duration, progress, past history, family history, diet history, whatnot. But in real practice, we rarely get through all this. Well, if somebody has a tonsillitis, you need not worry about all that. But if the problem is not the usual one, then learn to ask all the details almost like a new medical student. Don't forget to be as naive as a new medical student, especially when you feel the problem is something that you don't see often or see rarely. And this is one example. Moment you picked up a maternal uncle who dies of a similar process, which means that ultimately all his muscles, including the respiratory muscles, get involved and he dies of a respiratory failure. This is typical of a Duchenne muscular dystrophy. The reason I brought this is because such a child comes to you with a funny walking. He's walking, waddling like a congenital dislocation of hip. But that is because his both gluteus muscles are weak and he also has a toe walking, which means it's not only the gluteus but also the foot muscles are getting weaker. And I think that is where we have this diagnosis, but I'm happy that you all picked up so easily and well. Can I have the next slide, please? Yeah, this is another one, 8-year-old, okay, was seen walking on his toes for the last few months. He had no other complaints. And he shows spasticity of both lower limbs, and his uh, DTR are brisk. Okay, so your options are you have a Duchenne muscular dystrophy, or you have a peripheral neuropathy, or you have a spastic cerebral palsy, or you have a hereditary spastic hemiplegia. Your time starts now. Well, again, we are all divided, and I can see that this was not very easy for all of you. Yes, I understand that. But again, I wanted to bring this simply because, can I have the slide back? Uh, I wanted to bring this to your notice only because that you had to pick up two things. One, this is not a Duchenne muscular dystrophy, largely because you have an increased deep tendon reflexes, which means that this is an upper motor neuron lesion. And therefore, Duchenne muscular dystrophy and peripheral neuropathy, both being a lower motor neuron lesions, are out. Well, it could be a spastic cerebral palsy, or it could be a hereditary spastic paraplegia. Paraplegia generally presents also with weakness, whereas if this was only a tone abnormality, then it's more likely to be a spastic cerebral palsy, and you may closely see whether his upper limbs are also involved. Well, this is just to again bring some confusing types of cases, which gives you a message of how to look carefully in many other details. Can I have the last slide in terms of cases? The last case. Next slide, please. Yes, this is a senior citizen who presented with walking stiffly with shorter steps and dragging his feet for the last few months. There was an increased muscle tone. That's the only positive findings in this elderly person. And your options are he has a peripheral neuropathy, he may have a visual impairment, that's why he's walking like this, or he may have an age related degeneration, or he may have a neurodegeneration. Your time starts now. Can I have the slide back, please? Well, if you talk about the peripheral neuropathy, then he is certainly likely to have not only just dragging, take a note, he's stiff. The muscle tone is increased. Now, when muscle tone is increased, it's certainly a spasticity, and spasticity means really it's something upper motor neuron and not lower motor neuron. So this is not a peripheral neuropathy. What about age-related degeneration? Well, age-related degeneration doesn't have just mild increase in muscle tone and coming with dragging of feet only for last 1 month or last few months. The age-related degeneration takes a very long time and slowly worsens, but this has become not only in terms of short steps, but dragging steps. And also, therefore, this child has got a very severe increased muscle tone. Okay. Now, if this is so, you make a note that he has very short steps. Okay. And he's dragging, he's not lifting. Therefore, this is an early Parkinson's. Okay. You might have to pick up Parkinsonism in very early in the course to possibly have a reasonable outcome. And this is the case I brought only to show you that early symptoms and signs, if you look very carefully, you might look at this. One thing, you looked at it as an increased muscle tone, so it has to be upper motor neuron lesion. And age-related degeneration does not have an upper motor neuron lesion. Largely, it becomes a peripheral lesion. Whereas if it's occurring in last few months, then it is likely to be a beginning of a neurodegeneration and not an age-related degeneration. Age-related degeneration takes a very long time, whereas the neurodegeneration takes few months. But point is, early pickup of Parkinsonism is possible today. And if you saw somebody at 60 years looking a little stiff all of a sudden in a short period, you think about Parkinsonism and not just the age-related degeneration. Having seen these different types of cases, the next slide, please. Investigations are not very, very important, but I wanted to bring out one more issue of investigation. And today, the orthopedic surgeons in particular do a detailed gait analysis by a very comprehensive uh, generation of a test, which is a computer generation of evaluation. And what does this computer does really is to give you an absolute numerical values of the stride of the foot angle and also about the stance phase and a swing phase. And what I talked to you about the four issues of gait, a stance phase, a swing phase, a stride, and a foot angle is easily picked up by the computer generated mechanisms, and therefore it's far more accurate. Today, there are centers in India where orthopedic surgeons do the gait analysis by computer generation of the images, and this is far more accurate to assess the gait. Well, it's required only in a rare situation where a mere clinical impression does not guarantee the final diagnosis. But today you have this facility. The rest of this thing we know that investigation would depend on what's the possible cause and where the possible cause is. Can I have the next slide, please? And so also the management. The management largely depends on the cause, as we know, and many of these problems, be it orthopedic related or neurologically related, are ultimately a need maybe physiotherapy, either post-operative or otherwise. But this becomes a special issue, and you and me possibly are concerned with only management, are concerned only with diagnosis and leave it to the experts. The last slide just takes home messages. Well, observation of the gait is an important point. Don't forget to do that. I think it offers a clue. Detailed history, of course, is important. Gait analysis can be considered in a selective cases, and a proper investigation and management really can make the life of a person much better in quality. Well, thank you very much. I'm sure I have overseeded a little time today, but
Hmm.
maybe you have a minute or two to ask any questions if available. Back
So,
to Anurag.
uh, thank you, sir. It was an excellent session as usual. With your permission, I am taking few questions. Uh, the first question is, how does gait help in the diagnosis?
Well, I think the first thing, gait helps from a distance to know whether you have a painful condition or a painless condition. And if it's a painful condition or painless, it further helps to define the site of affection. And then that leads you to proper examination, a focused physical examination. Beside that, of course, I did mention the gait of a person also tells you how confident and physically, mentally fit he is. Okay, which is a different story altogether. And I think, therefore, I wanted to impress on you many of such simple things in life are not given adequate importance, but at times you can score over your colleagues straight away by going through such small little things. And they are possible. You try this and you will enjoy practicing medicine.
So, another question is, what are the examples of painful neurological diseases?
Well, pain is caused by affection of either nerves or the blood vessels. If the blood vessel is obstructed and it causes the anoxia or hypoxemia of a given site, then it causes pain. We know myocardial infarct is a vascular pain, and so also neurogenic pain. When the nerve is irritated, like the spinal nerves, in terms of a spinal disease or a vertebral column disease, then you get a pain. But friends, this pain has some peculiarity, as against the inflammatory pain. And what is most peculiar is one, it's of an acute onset. Okay. A myocardial infarct is an acute onset pain. A Perthes disease is an acute onset pain. Well, it may become chronic over time, but the onset is acute. And another is a type of pain. A neurogenic pain is a pain like an electric shock or a burning pain or a pain that is going across the direction of the nerve. And I think learn to ask details about pain, and then you know that non inflammatory pains are not common, but certainly seen in practice, but a good history can make out easily.
Another question is, which problems are usually missed while diagnosing limping gait?
Come again?
Which problems are usually missed while diagnosing limping gait?
Yes, I think what is important in all our discussion really is that yet you can pick them up very early in the course of illness. And friends, today we know that early diagnosis of every disease is very important for a best outcome. Finally, we make a diagnosis. Well, sometimes we make a diagnosis on postmortem also, but that is too late. And therefore, the whole idea of this GP webinars, which Anupam has been really in the front line to disseminate knowledge in varieties of ways, and one of the ways are these webinars, that we want to come out with the best possible way of dealing with patients, not only with art but also with science. And friend, this is important because science of medicine has limitation. We cannot always be right, but we can try to make ourselves right as often as possible. And I hope that the messages are clear about all this.
So since we have already exceeded time and lot many questions are trickling in, I hope we'll be covering all these questions in the print edition of GP Clinics with answers to all of them when we publish this summary in the next issue. So with this, we are coming to an end of the session. Thank you, Dr. Amdekar, for this wonderful session.
Thank
We hope
you.
we hope this interactive session would have made learning interesting for attending doctors to help empower their practice. On behalf of Clinics India, doctorslive.com, and GP Clinics, I thank all the doctors who have attended this session. So please note the date for the next webinar. It will be 27th of October 2024, Sunday 11 a.m. The topic would be clinical approach to hepatomegaly. So friends, thank you once again to all of you. Good day.
Good day, friends. Have a nice Sunday. Thank you.
Thank you, sir.